This conference will now be recorded.
So, as you already know about the adrenal glands, they are paired glands located on the top of the kidney. These are very important purposes. Though they are very tiny in size, the purpose of these is very significant in homeostasis in the human physiology. So, in this class, we will discuss about basic anatomy and physiology. And in the next class, we will be discussing about benign and malignant adrenal tumors. Basic anatomy and physiology could come as a question for you. You need to concentrate on this topic. So the adrenal gland consists of two parts. You already know one is the cortex in the medulla, outer cortex and inner medulla. So these two are embryologically different, and they are having they function separately, and they're having very different roles. So the cortex cells, see for see, there is coelomic epithelium, which is a component of the mesoderm. So cells of the medulla are derived from the neurotrus. So both the paired suprarenal glands. If you take a look at the anatomy of these glands, outer line depicts the cortex, outer white line. The inner one is the medulla, which is covered by the blood vessels and all. This is surrounded and surrounded by a capsule. So if we take a look at the right side of the image, the two and the paired suprarenal glands they sit in the top of each kidney. Clearly notice in the picture, which is surrounded by the gerotous fascia, fibrous tissue. So gerotous the fat the phase to the environment, the system is related to the system that the kidney. So upon gross examination, the outer cortex is mustard yellow in color and the medulla is brown in color. So these are very tiny glands, but the function is very important. Roughly around 4 to 5 grams each. So the length is roughly 4 to 6 centimeters and width is 2 to 3 centimeters. Both the right and left adrenal glands differ in the shape. The right one is triangular in shape and the left one is crescent shape. So these tiny glands regulate very major functions by secreting many hormones and participating in metabolism. So this is a perception of adrenal glands, which shows, as you can appreciate in the picture, these are very tiny glands, roughly around 4 to 6 grams in size. These are the normal adrenal glands. The perception is adrenal. So outer cortex is a golden yellow or mustard color, and the inner one is roughly brown in color. Lastly, this is utilizing gerotous fascia at the level of the 11th and 12th ribs. So right adrenal gland is a little definite compared to the left one. So the boundaries include anterior, it is superiorly and laterally enveloped on the right side by the diaphragm. Anteriorly, it's liver, and superiorly and posteriorly, it's diaphragm. On the right side, inferior vena cava is situated. So medially, it's in inferior vena cava. So middle part of the gland, sometimes it's retrocaval and means it is behind inferior vena cava in position. So right adrenal vein, enters into IVC in posterolateral position, as some part of the gland, the medial part of the gland is retrocaval. The corresponding vein enters posterolaterally. So these are the relations of the right adrenal gland. On the left side, it is bounded by left viscera. Posteriorly, it is bounded by diaphragm. On the right side, superior boundary is also the diaphragm. On the left side, you need to take a left side, it is spleen. Anteriorly, right side it's liver, and left side it is stomach, pancreas, and splenic vessels. Inferiorly, both it's kidney. Here, the medial boundary is aorta. So, to the right, medial side of right adrenal gland is inferior vena cava, and medial side of left one is the medial boundary is aorta. So these are the boundaries and anatomical relations of adrenal gland. So this picture clearly shows you the anatomical relations. On the right side, it's anteriorly liver, and posteriorly and superiorly it's diaphragm. Inferiorly it's right kidney. On the left, side, the anterior relations include pancreas, splenic vessels, and stomach. And in the medial, it's abdominal aorta, and superiorly it's spleen. So these are enveloped, adrenal glands are enveloped by the gyrotous fascia. Continue. So, arterial supply is roughly about 7 cc per gram per minute. So the blood supply is from 3 arteries: superior, middle, and inferior adrenal arteries. So they are the corresponding branches. Whereas superior adrenal artery, it arises from inferior phrenic artery. Superior, it's diaphragm. You can remember like that. And middle adrenal artery, which is the most important, which arises directly from the aorta, abdominal aorta. And inferiorly, it arises from the ipsilateral renal artery. So 3 arteries which supply. These 3 arteries together, they form a subcapsular vessels, and from the subcapsular branches, so some of the branches, some the subcapsular plexus, some of the branches they directly travel to the medulla, other they travel from the sinusoids to the cortex. So these constitute the arterial supply. If you could clearly remember, superior, middle, and inferior. Superior, as the superior relation is diaphragm, you could remember it's inferior phrenic artery, and the middle it's directly arises from the abdominal aorta, and from the inferior renal artery, ipsilateral renal artery, the inferior adrenal artery arises, and from there they form the 3 of these arteries, they form a subcapsular plexus. From the subcapsular plexus, some to the cortex and some to the medulla. Coming to the venous drainage, all these medullary veins. In the previous slide, I clearly showed you in the medulla. Just wait 15 minutes. Here's the image. Here, the medulla, if you clearly see, these are the blood vessels. So these medullary veins together coils to form the adrenal vein. So the right side and left side drainage is literally different. Both of the adrenal veins, they open into different veins. Coming to the vascular supply, already we discussed about the arterial supply. Still hanging in just a few minutes. So on each side there is a single main adrenal vein, which is found by the coalescence of the medullary veins. So right side, as we already discussed, the right side the medial boundary is inferior vena cava. So it is close to the inferior vena cava. So the right adrenal vein is short and it drains directly into the eyes. Whereas on the contrary to the left side, if you clearly remember the anatomical relations, definitely there is an aorta and then inferior vena cava. So left adrenal vein should be longer compared to the right. So it is joined by inferior vein. Both of these they drain into left renal vein before joining the IVC. So both are overlapping. In the previous slide, we discussed how blood vessels, arteries, and veins are there in the adrenal medulla. These overlapping makes partial adrenalectomy is possible, and there is a blood supply from three different arteries. One is superior, middle, and inferior. So partial adrenalectomy is possible in case of benign tumors or early malignant tumors. So the segmental blood supply allows for a partial adrenalectomy. So in this slide, you can clearly see the right adrenal vein, which drains directly into the inferior vena cava, whereas contrary to the left adrenal vein, which is longer in course, as it has to come from a distance to join in the left renal vein. So this left adrenal vein is joined by left inferior phrenic vein before it enters the left renal vein, which ultimately drains into the IVC. So this picture clearly demonstrates right one is triangular in shape, left one is crescent shape, sitting on the top of the respective kidneys. So which one is more prone for obstruction, either the left or right side? If you take a clear look at this picture on the corresponding right renal artery and left renal artery, so renal artery can be compressed. That is one clinical point. So one of the abdominal, there are chances of compression of renal vein between this abdominal aorta and this branch, which could cause hypertension and secondary renal issues. So coming to the nerve supply, the sympathetic supply comes to the medulla. It comes from the preganglionic sympathetic fibers from the sympathetic trunk directly to chromaffin cells. They strain positively, so that known as chromaffin cells, which from the cortex receives nerve supply from the postganglionic fibers from spine and ganglia. So parasympathetic to adrenal cortex and medulla, they are not well defined. So vagus may send some branches. You need to remember that the parasympathetic nerve supply to adrenal glands is not well developed. Lymphatics, right adrenal, as it lies behind the medial boundary of the right adrenal gland is the inferior vena cava, so it is lying besides the IVC. So the right adrenal it drains into the paracaval lymph nodes, whereas the left adrenal it drains into the para-aortic lymph node. Just remember, right one lies adjacent to inferior vena cava, left adrenal lies adjacent to aorta, abdominal aorta. So the lymph nodes which are parallel to these draining vessels. So coming to the histology, it is surrounded by outer capsule, and after the capsule, adrenal cortex, and then medulla. Cortex, which strains more compared to the medulla, which capsule is surrounded on the outer side by the gyrotous fascia, and in the outer layer, there is adipose tissue, fatty layer. So the zones include the cortical zones include adrenoglomeralular, fasciculata, and petricularis. Just you can remember these zones as GFR, glomerular filtration, right? Just like that. Outer one is zona glomerulosa. Middle one is just like bundles of tissue. So it is known as fasciculata. And inner layer of cortex is zona reticularis, which forms reticulum of network in histological appearance. And inner is adrenal medulla. So we already discussed the three layers of the adrenal cortex: glomerulosa, fasciculata, and reticularis. So the function of the adrenal cortex is secretion of steroid hormones. All the adrenal cortex hormones are steroid. Unlike other hormones, these are not stored and released. They are synthesized as per the requirement. So each layer of these, they have different function. The adrenal cortex, which comprises of three layers. So outer layer of glomerulosa secretes mineralocorticoids. Middle layer of fasciculata secretes glucocorticoids, and inner layer of zona reticularis secretes androgens. So these three layers, they differ in their secretory function. So you need to remember one more thing: they are not stored. Whereas in case of thyroid hormones, just like in other adrenal glands, mostly they are stored and released as per the requirement of the body. So these are not stored, synthesized as and when needed. So the main precursor of steroid hormones is the common metabolite from which these hormones are synthesized is cholesterol. Depending upon these layers, outer layer is secreting mineralocorticoids such as cortisol and corticosterone. Middle layer glomerulosa secreting aldosterone, and inner layer androstenedione, just androgens. So depending upon first, cholesterol is converted into pregnenolone in all these cases. Depending upon the secretory function, it is either converted to 17-hydroxy or directly converted to progesterone or 17-hydroxypregnenolone. So outer layer of fasciculata, which secretes mineralocorticoids, cortisol and corticosterone. Glucocorticoids of zona glomerulosa, aldosterone. Inner layer of zona reticularis, androstenedione. So depending upon these functions of the different layers, they are having different reactions like oxidation, hydroxylation, and isomerization reduction. These finally gives rise to the corresponding aldosterone, cortisol or corticosterone, and androstenedione. If androstenedione it undergoes reduction reaction, then there will be testosterone. Depending upon the aromatization, there is estradiol production. So these peripheral aromatase inhibitors, if you need to use them in breast cancer or other cancers, it works here, reducing the production of estradiol. So zona glomerulosa, most superficial layer, it lies directly beneath the renal capsule. Cells are ovoid. These are in Latin, the word glomus means ball. So glomerulosa, which is responsible for secreting mineralocorticoids, namely aldosterone. So what is the function of aldosterone? So it is released from the adrenal cortex and depending upon it regulates the level of potassium and sodium. So whenever the level of potassium in blood rises, aldosterone is released, or the sodium level falls. Aldosterone targets kidney, and it results in the main function of which acts on the disc collecting tubule DCT. Really, the function of aldosterone is to improve it promotes sodium reabsorption and promotes potassium excretion. So sodium is reabsorbed by the kidneys and potassium is excreted. So the ratio of sodium and potassium levels normalizes. So you already know sodium potassium ATP is, and many functions are dependent upon this ratio of sodium and potassium levels. So the main system which is regulating the fluid balance and corresponding electrolytes like sodium and potassium is the renin angiotensin aldosterone system. So liver secretes angiotensinogen which is converted to angiotensin 1. So angiotensin 1 is converted to 2 by angiotensin converting enzymes which is secreted by the surface of the pulmonary and the renal epithelium. So these inhibitors act on this, and kidney by releasing renin, which influences angiotensinogen to become angiotensin 1. So the stimulus for release of renin is decrease in the renal perfusion. So decrease in the juxtaglomerular apparatus perfusion. So angiotensinogen which converts to angiotensin 1 and angiotensin 2 by angiotensin converting enzyme. So this angiotensin 2 has a wide functions like the main function related to today's topic is angiotensin 2 promotes the secretion of aldosterone secretion which acts in the cortex, and aldosterone which regulates the sodium and potassium levels by acting on the tubule of kidney. So angiotensin 2, the other is increasing sympathetic activity. So arterial vasoconstriction, and it promotes increase in blood pressure. So it stimulates the postpituitary, results in the ADH secretion. Finally, all these components, if we take it clear look, the final thing is it helps in improving blood pressure. Main function is water and salt retention. And the stimulus is and the when there is hypovolemia and there is decreased perfusion of the juxtaglomerular apparatus, renin gets secreted, and which stimulates the renin angiotensin aldosterone system, in shortcut known as RAS. So this is the main mechanism of renin angiotensin aldosterone system. So its main function is water and salt retention, increase in so arterial vasoconstriction. In this slide, you can clearly see decreased sodium, decreased perfusion. There will be renin release from the juxtaglomerular nephrons, which converts angiotensin produced by the liver into angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by the converting enzyme, which is secreted by the pulmonary and the renal surface epithelial cells. So this angiotensin converting enzyme is ACE inhibitors, which is used for the control of blood pressure. They act here. So angiotensin 2, depending upon the function, angiotensin 2 has a wider approach, just like stimulating the release of aldosterone. and arterial vasoconstriction, and pituitary releasing posterior lobe, stimulating posterior lobe of the pituitary to release vasopressin antidiuretic hormone, so which ultimately helps in water and salt retention, so which further causes increased blood volume and then increased blood pressure. So this is the compensator mechanism. So clinical significance, we already discussed about angiotensin converting enzyme inhibitors, which is used in hypertension. So other is angiotensin receptor blockers or antagonists. So direct renin inhibitors can also be used. These drugs are aliskiren and remikirin, and the vaccines are being investigated. So the main purpose of renin-angiotensin aldosterone system is water and salt retention. So coming to the fasciculata between the glomerulus and reticularis. So its main function is secretion of glucocorticoids, cortisol and corticosterone. So cortisol secretion is primarily regulated by the ACTH secreted by the pituitary and adrenal vasopressin. So you need to remember this point. In the healthy people, secretion of the cortisol secretion, mineralocorticoid secretion is pulsatile, and in a natural circadian fashion in the biological cycle, these levels fluctuate. So early morning, the levels are highest and lowest around mid. So these levels you need to measure in case of any dexamethasone suppression test or any Cushing syndrome and all. So you need to remember the cortisol secretion is pulsatile according to the circadian rhythm. High levels are secreted in the morning and lowest around the midnight. So this is a circadian rhythm. Stimulus is hypothalamus releases corticotropin releasing hormone, which stimulates the pituitary to release adrenocorticotropic hormone, which stimulates the adrenal cortex to release glucocorticoids. So this variation, as you on the right side of your screen, there is an diagram. On the y-axis, the concentration of the cortisol, and on the x-axis, time. As you could clearly see, it is high in the morning and lowest in the midnight. This circadian rhythm. So glucocorticoid it helps in regulating the glucose metabolism, adrenal cortex origin, and steroidal structure. So naturally occurring glucocorticoids are these are part of the feedback mechanism which body utilizes to reduce the immune system. So exogenous glucocorticoids are caused by overactive immune system in case of allergies and anaphylactic reactions. So this function is anti-inflammatory. It is immunosuppressive. Helps in the metabolism of glucose, fats, and proteins. So it helps in gluconeogenesis and in the catabolism of fats and proteins. So protein catabolism and lipids are degraded by the process of lipolysis and bone resorption. So all these. So if you use exogenous steroids in high doses, there is glucocorticoid induced osteoporosis, which is a side effect because of its action on the bone, leading to bone resorption. And the other is mainly anti-inflammatory and immunosuppressive. These are the therapeutic side effects. So, which could be side effects include, as we already discussed, one is it plays a role in mainly in the glucose metabolism. So, if used in excess quantity, because its main positive effect on gluconeogenesis and all, there will be hyperglycemia and weight gain, fluid tension, and Cushingoid appearance. Because of bone resorption, the side effects include osteoporosis, avascular necrosis of the femur, and it is immunosuppressive, anti-inflammatory. So the side effects are infections and all. So other include posterior subcapsular cataract, glaucoma, side effects on the eyes. In case of a cardiovascular and renal insufficiency, the side effects is hypertension. These are the various effects and side effects. So zona reticularis is the innermost layer. These small cells arranged in a net-like pattern, reticular pattern, which is surrounded by connective tissue and capillaries. So it produces androgenous known dehydroepiandrosterone and DHA sulfate, androstenedione. So these are the precursor of steroids, testosterone in males. In case of females, there will be aromatase, which gets converted into estradiol. Immediate sex steroids, these are the precursors of testosterone and estrogen. So till now we discussed about adrenal cortex. Now we will discuss about adrenal medulla. Adrenal medulla is relatively less in contribution, constitutes of less than 10% of the adrenal mass. So, but the main important hormones secreted by the adrenal medulla is catecholamines like epinephrine, norepinephrine, and dopamine. So, sites of synthesis, we all previously in the development we discussed the hormone from the neural crest of neuron to the. So, they also these hormones are also can synthesized from CNS, chromaffin cells of the adrenal medulla, and postganglionic adrenal medulla. So the shortest half-life of these is epinephrine or adrenaline. So stress results in increased production of catecholamines and glucocorticoids. The, the phrase is normally known as a fight or the flight response. So this is the cycle of secretion. So the catecholamine degradation, which is catecholamine homomethyltransferase and monoamine oxidase. In case of the final metabolism is vanillin acid. So it is used in as a diagnostic test in case of pheochromocytoma where there is excess secretion of catecholamines and also in neuroblastoma. So increased VMA levels in the urine is one of the diagnostic tests used for pheochromocytoma. So this is the sympathetic activation is one of the main reasons. The fight or the flight reaction. Other mechanism is the catecholamines which bind to various adrenergic receptors. G protein coupled receptors which lead to fight or flight response. So these are the subunits and corresponding regulations. The take home message is GFR. As already I discussed with you, is GFR, glomerular fasciculator and reticularis. These are the managing general agents of hormone synthesis. Glomerular fasciculator, reticularis, and inside there is adrenal medulla. The hormone secreted corresponding to aldosterone, glucocorticoids like cortisol, corticosterone, and inner its reticular secretes androgens, dehydroepiandrosterone, DHEA, and adrenal medulla, the stress hormones, which is epinephrine and norepinephrine.
ఎప్పుడు పెట్టేస్తా అయిపోయింది కదా పెట్టేయచ్చు
Adrenal